everyone. I am so blessed to be here today with Matt Tyler, also known as Dr. Matthew Tyler, or you might know him as How to Train Your Doctor. He's a doctor who's dual board certified in internal medicine, as well as hospice and palliative medicine. And he has over a decade of clinical experience caring for patients and their families in hospital, clinic, and home-based settings. And beyond that, he's a passionate believer that social media is both a powerful and meaningful tool for public health education. So that is a lot of why we're here today. We're here to have a discussion to dispel some of the myths around palliative care. So let's get started. Welcome, Matt.
Emily, thanks so much for having me.
Of course. So I think the number one question we should start with is that people generally have a fuzzy understanding of what palliative care is. So tell me what your definition of it is.
All right. Great place to start. So palliative care is a medical specialty, just like any other specialty, cardiology, oncology, and our focus is on your quality of life. So we focus on the symptoms and stressors related to a serious illness like cancer or heart failure or dementia. And we help make your quality of life as good as it can possibly be while you're getting treatment for your illness. And when it comes to the most common misconception, it really is that palliative care needs to be instead of your treatment, when the reality is you can get palliative care alongside all your other disease-focused treatments.
Okay, so where does that myth tend to come from?
And I think that myth comes from the historical roots of palliative care. The reality is hospice did come first, that we started with end-of-life care, hospice care, and we, as a field, saw how meaningful hospice was for people near the end of their life when we took this kind of radical new idea of, team-based, holistic support with a focus on the person and their quality of life rather than the disease, and fighting the disease as strongly as possible. We saw the healing that could happen even in the absence of cure. And we thought, wow, wouldn't it be cool if we could provide a similar approach to care before someone was in the last months or days of their life? And that's really where palliative care came into the picture, was trying to take the philosophy of hospice care and apply it earlier on in your life at the beginning of an illness rather than the end. And with that came the pairing of palliative to hospice care. It's in my board certification title. I'm board certified in both. So they share that philosophy. And because they share that philosophy, a lot of people still kind of conflate them as synonyms rather than cousins.
Yeah, so we don't need to necessarily marry it to end of life. It could be for anybody of any age at any stage of illness, correct?
Exactly right.
Okay, all right. So how, who would be a good candidate then for it? Because it sounds like it's not maybe who we think.
Really, anyone dealing with a serious illness, which we typically describe as something that will likely be what you ultimately die from, whether that be days from now or years from now. If you've got a serious illness, along with concerns about how it will impact or is impacting the quality of your life, palliative care would be a great team to meet with. And they can talk to you about symptoms and how they're interfering with your day-to-day. They can give you space to talk about and plan for the future, and provide you emotional support, help you with coping with it all, coordinate care, making sure that you're getting clear information about what's going on and what your options are, to really aim to maximize quality of life and keep you in the driver's seat of your care plan.
Can you give me an example of what that would look like of someone who, might have gotten a terminal diagnosis but still has years to live? So how would palliative care intertwine into their day-to-day?
Yeah, so a classic example would be someone with a brand new diagnosis of stage 4 cancer. And they have a ton of treatment options on the table. And in fact, likely to live 2, 3, 4 years with treatment, with the understanding that this is treatment meant to slow the growth, not cure the cancer. And so where palliative care would kind of get involved from the beginning to just understand this person, what's important to them. You working right now? What's your family look like? And how do we help you maintain a normal life unimpacted by this disease for as long as possible, manage the pain associated with that, manage whatever symptoms or side effects you're having from the treatment, while helping kind of slowly start to dive into questions about the future, making plans for when the treatment stops being so helpful, when the disease
Hmm.
starts playing a bigger role in your day-to-day functioning. And really, the earlier we can do that and get to know each other and build that relationship, the easier it's going to be to kind of have that relationship, to have that mutual trust and start to talk about those difficult things as they become more relevant.
No, I love that. So, how are you working with their like cancer doctor, for example? Like, how does that relationship work in the hospital?
So in the hospital setting or in the clinic in the cancer treatment center, our model is that one of the main physicians involved in their care reaches out to me and says, "Hey, I really think this person could benefit from your support." Uh, I want to clarify though that doesn't have to kind of go that
Hmm.
way. Every hospital and clinic works a little bit different in terms of who can send the referral. It doesn't always have to just be a doctor. And in many cases, a patient can self-refer. And I often encourage patients speak up and ask for a palliative care referral if they think it's something that could be of benefit to them.
Yeah.
But typically they're reaching out to me and saying, hey, this person could really use some help with pain management, or this person really seems to be struggling with coping with what's going on. Can you just check in with them? And we go from there.
I love it. But it sounds like not every doctor might offer that. So, like, how can people advocate for themselves or have their families advocate for them?
The easiest way is to just ask for a palliative care referral. We have data that show that while on one hand, docs tend to wait until later into the disease to involve palliative care, and truly when it would make more sense to be talking about hospice care rather than palliative care. If a patient asks for a palliative care referral, most of the time the docs are happy to facilitate that and make that
Hmm.
referral. And not all the time, but it is certainly, it works more often than it doesn't.
Okay, so it sounds like it's never too soon to ask for it.
I would say yes and no.
Okay.
I think the context has to kind of be a serious illness in place. So,
Hmm.
whether it's, stage one or stage four cancer, for example, we say we see people at any stage, any age, as you were alluding to earlier. But typically, there needs to be some underlying serious illness as sort of the pretense for our involvement.
Okay, so is there some sort of significant turning point people should look for to like know that this is something they should ask for or have the conversation?
I think certainly any chronic illness that's sort of landed you in the hospital would be a good reason to check in. So if you're living with heart failure or COPD, using oxygen at home, getting hospitalized on top of that, it tends to be a fairly medically significant event where it's worth a
Hmm.
check-in to talk about what's going on and how we can best take care of you. Certainly a later stage cancer diagnosis, stage three or stage four, tends to come with harsher treatments, more symptoms. You may need help supporting yourself through that, getting pain control in place. Those would be good reasons to talk to us as well. Or caregiver taking care of someone with dementia. It's becoming more stressful providing care at home. A conversation about what we're doing, why we're doing it, how we can maximize support for patient and caregiver alike. We can certainly check in those
Yeah.
situations too.
So it sounds like this isn't just about the individual who has the diagnosis. It like involves their whole family. Can you speak a little more about that?
Part of our holistic approach is not just that we bring multiple disciplines to the table, like docs, nurses, social workers, and chaplains, but really treat the patient and family as a whole unit, or at least recognize this patient doesn't live in a vacuum. Typically, there are
Hmm.
friends and family that are important to them, whether they be blood relatives or chosen family. We, get a sense of who are the important people in this person's life. Where are they drawing strength from, and how do we help you lean deeper into those relationships and draw from that strength in a way to help you carve a path forward when it comes to living with your illness.
It sounds like I've also heard there's like stigma in this space, and like I feel like maybe if a family is curious about this, they also worry about suggesting it. Is that true? They don't want to like make it feel darker
Yeah.
than it is.
Yeah, so a lot of this will depend on what's going on with the patient and what their capacity is to call their own shots for their care. So obviously, if someone is living with cancer and they don't want to tell their family about their
Mm,
diagnosis or include them, I'm not going to insist that they include family and say, no, you need to do this. It's not about taking a paternalistic approach or forcing a model of care on someone that doesn't find that therapeutic. But we might talk about why. Like, tell me what's going on with your life and tell me about that. If that is true and you're sort of distant from your family, typically that, you think about it, it might weigh on you. We might talk about how do we work through that and what are the pros and cons of involving them, for example, or who are other important people in your life that we can bring in as that source of support instead. Obviously, very different than someone living with advanced dementia who may not be able
Hmm.
to make their own medical decisions, and there is a family or caregiver or relative of some sort directly involved in care coordination, in which case we are kind of absolutely kind of taking care of both caregiver and patient as we talk about how to provide
Hmm.
support to them.
Yeah. So I know we've talked a lot in the abstract about like how this works, a little bit about the families, but do you have, I know you can't talk in specifics, but any success stories so people can like really see how this is in action?
A lot. I think about the one patient I had years ago who had, a fairly advanced cancer, and I got called in initially to help with pain control. Um, but he was also dealing with a lot of, I think, emotional issues related to their choices about their cancer treatment. They were given the option of more toxic, potentially curative treatment, but would come at a very significant cost to their quality of life that they had opted not to do and to do more conservative treatment for their cancer, with acknowledging the trade-offs that would make. Uh, and in that context, I was helping manage their pain, and we worked with each other for many months, maybe even over a year. And along the way, we talked about quality of life, and I would challenge him on what he's doing for fun, what he's doing to connect with family and friends, things that he had told me were important to him. Uh, and as the illness progressed, we would talk about that too and how it was getting harder to do things while still finding those meaningful moments and how to maximize quality of life. And there was a lot of that in with the real talk. We would talk about prognosis and making plans for the end of his life as much as we would talk about how to find meaning and joy in the pockets of time that he had. Uh, and I was often, I would always find it easier almost to talk about kind of the harder stuff, like the prognosis and end of life care planning, because that's certainly where a lot of my training was. Uh, and it would almost be more of a push for me to talk about the meaning and joy, to not kind of project too much or be too. I really don't like the silver lining, everything happens for a reason stuff. And
Yeah.
I don't even want to like accidentally like feel like I'm doing that to anyone. And so I would always feel a little self-conscious about that stuff. But when he was very near the end of his life, he was coming to one of our last appointments, and his son was with him, and made a comment about how his dad always loved coming to these appointments because I was like his cheerleader,
Hmm.
and I always felt like I was supporting him even while talking about end of life care and life expectancy and helping him tie up loose ends. Even while doing all that stuff, I was sort of positioned as his cheerleader, and I just was really taken aback by how favorably he looked at me just despite all
Yeah.
that. And that one's really stuck with me.
I love that story so much. It seems like you're sort of like defining and shaping this role as you go, and it like involves so many more things than what we just think of as like a traditional like hospital doctor patient relationship. Like, what is the interplay of mix that you would say it involves? It sounds like you're a therapist and friend and cheerleader, but how would you define it?
Yeah, in a lot of ways, I sort of function as like the spackle of your
Yeah.
foundation. That whatever I'm doing for any individual person largely depends on where the gaps in their care are, and that can be different for many different people. And in some cases, they may feel like they're not getting a clear message from their oncologist about the intentions of treatment or their prognosis. In other situations, they may be wrestling with going to a nursing home versus going home and what trade-offs are involved in that, or whether or not a feeding tube makes sense, or
Yeah.
if long-term life support makes sense, or they just need someone to sit with them and validate that whatever's happening sucks and they feel like no one's acknowledging that, or no one is, talking straight with them. Even if there's no fixes per se, just someone to sit down and acknowledge
Hmm.
how terrible things are, that can have an incredible therapeutic value for people too. So it is hard from a public education point of view when someone says, okay, but like I hear your definition. Yeah, you focus on quality of
Hmm.
life, but what do you actually do? Like, what would you do
Yeah.
for me? Because it is so highly individualistic. And so my question is always, well, what's stressing you out? Like, what's the
Hmm.
main ways that your illness is getting in the way of just having a normal life? How do you define that? And how can we get as close to that as possible? And what's it going to take to do that is going to highly depend on the person and their situation.
It sounds like you very much see the person and the individual and like choose to be present with them in a way that doesn't often happen. Is that one of the reasons, based on just like kind of how transactional some of the system is, that more people don't end up being able to get palliative care?
I think I talk a lot about healthcare having this default pathway, and the traditional healthcare model in the U.S. and most Western regions is very disease focused. The disease happens to live inside of a person, but the healthcare delivery model is focused on uh, identifying diseases, diagnosis, and treatment of illnesses and aggressively pursuing cure or management of that disease, no matter the expense on the patient, the individual's quality of life, and what that looks like for them. So palliative care is kind of just a very much a different model of person-centric, holistic approach to care. And that it's much more about how the disease is impacting the person and how we can lessen the impact on the person, um, rather than what are we going to do about the disease itself. And there can often, I think for a long time, there's felt like there's a bit of a conflict there when I strongly disagree with that. I think palliative care
Hmm.
is a wonderful complement to the disease-focused care to make sure that nothing is getting missed along the way.
Yeah, I love that. I think you told me before that the medical system is currently built to intervene and escalate care rather than
Yeah.
sort of like sit in the discomfort. Is that accurate?
Yeah, that's part of that default pathway where as we pursue like treating diseases as aggressively as possible, we will escalate to the point of death, whether you're on life support, on a ventilator, on feeding tubes. The default pathway is to keep you alive as long as medically possible, no matter the condition you're in. And sure, there are some folks that are sort of okay with going along for that particular ride. But there's a lot of folks who are not okay with that. And there are a lot of folks who would draw a line in the sand and say, if the only way you can keep me alive is on a machine with tubes coming out of every which end, then please do not keep me alive that way. Just let me go at
Hmm.
that point. And the we aren't really trained in how to have those conversations. That's not really
Hmm.
part of medical training. You hopefully pick that up somewhere along the way from an attending mentor, in residency and beyond. But medical school does not dive into talking about end of life, complex decision making, when the emotional stakes and
Hmm.
physical stakes are very high. That's not part of the
Yeah.
base training at all. And what the How to Train Your Doctor refers to is trying to uh, bring that conversational comfort to everyone, both patients and clinician alike.
I love it. And I love that your name is How to Train Your Doctor. So, like, let's practice. Give me like three sentences if I needed to advocate for this of like how I would do so or start the conversation.
So if you're living with a serious illness or taking care of someone, um, honestly, I've shifted my answer to this along the way.
Oh, okay.
So I will. Originally, when I kind of came up with the How to Train Your Doctor handle, it was more so about giving you, the patient or the caregiver, things to start a conversation with your doctor for.
Hmm.
So those things would be sentences like, "Hey, I just want to be very clear that quality of life is very important to me. And I want to have a conversation to make sure that we balance my quality of life against living as long as humanly possible, because I don't want to go down that road. Could you tell me more about how we would balance that with my care plan today? Are there any modifications we should make to what we're doing knowing that quality of life is important to me. Um, and over the years of me doing this, a lot of people come back to me and say, you know what, I tried it, but like my doctor didn't really engage. I didn't really know what to do with
Hmm.
that. And so these days, really, when we talk about what can you say to advocate for yourself when quality of life is important to you, the number one thing that I'm encouraging folks to say is, can I get a referral to palliative care?
Okay, so just knock off all the rest of it. Just ask for it.
Just, yeah, cut out all the fluff and ask for that referral to, and it really is the best way to ensure that if quality of life is important to you, you got concerns about the present or the future, that you're going to have a team trained in navigating those things with you,
Hmm.
who really knows the ins and outs of symptom management, complex decision making, emotional support, psychosocial supports, stuff that, while it would be nice if all clinicians were adept at doing that, the reality is there's an incredible variability in their competence, and there's an incredible shortage of time to be able to engage to the depth that a lot of people need to feel a meaningful impact.
Yeah, how are you able to get the time required to like spend with these people and feel like you're being effective? I know it's a difficult question, but
Yeah, I think I am lucky that we have a system set up where um, I do have the time. I think a lot of it is I am not seeing 20 patients a day or 30 patients a day compared to the primary care providers or oncologists. I mean, they just the amount of people they have to see in a given day is just astronomically larger than mine. So I'm lucky that our structure is built that I have that
okay.
time to sit
Thus
down
we
with
just have
them.
to
Yeah,
ask directly, give me this
yeah,
thing.
yeah,
Yeah.
yeah. Yeah,
Well,
and I
that's
and I think for a lot of folks when you're living in it and you're dealing with an illness and treatment or a caregiver, I try to be very sensitive about asking you to do even more and to take even more on your
Mhm.
plate when you're already juggling so much and
Yeah.
spinning so many plates. I try to make whatever I'm asking of you as light a lift as possible and to try to outsource as
Hmm.
much of the support as I can in a way that you're going to feel as supported as possible, as quickly as possible.
You're the best cheerleader, I can already tell. That man was right.
I am
Um,
ruthlessly pragmatic, as I say. Yeah.
I'm like, I could see your pom poms, the virtual pom poms. You said specifically, like you kept saying quality of life. Is that important to say like that specific language? Is that necessary?
Yeah, there is a bit of a medical like codification
Okay.
to that phrase. You know, in the medical world, uh, quality of life, invoking its importance is sort of a way of signaling I don't want to end up on machines like in a
Okay.
vegetative state, tubes or whatever. You're kind of expressing that you've got a limit to how much you're willing to push your body beyond its natural limits.
Okay.
And it's sort of typically the most universal phrase amongst medical people. If you're saying quality of life is important to you, they sort
Okay.
of understand that's a signal to kind of talk about the ins and outs of treatments with a bit more nuance and not just presume that you want to chase every single treatment regardless of side effects, regardless of
Okay.
what condition you'll be in. Yeah.
So even if you're not sure that like that's a specific path that you want to go down of like the I care more about quality of life than any means possible, like people can still ask for this, right?
Absolutely. And quality of life is a very subjective thing that means different things to different people. And what it means to one person evolves over
Hmm.
time too. Um, and quality of life is, it doesn't have to be a binary thing. It doesn't have to be quality of life or survival. For most people, they're trying to strike a balance of living as good as they can for as long as they can.
Hmm.
And there's often, disease-focused treatments involved in there. There may be hospitalizations involved in there, but there can also be symptom management support, emotional support, spiritual support. It can be a both and thing, and that's really
Hmm.
the whole point of palliative care is to say you don't have to choose between aggressively fighting your disease or getting holistic support. Like we can and
Yeah.
should be
I
doing
love that.
both.
Yeah. So there's lots of options. It's not just like you pick a path and you're down it and that's it forever. That's
Yeah,
a good reminder.
yeah.
Um, I love it. Well, is there anything else that we haven't covered that you want to make sure people absolutely know?
I think if nothing else, if you are living with a serious illness and quality of life is important to you, tell your medical team you would like to meet with palliative care. And if they are not sure how to connect you to palliative care, there are a couple ways to do that that I always like to let people know about. One is the registry, getpalliativecare.org. It's run by one of our national palliative care associations. Type in your zip code there, and you can kind of check a box if you're looking for home-based support, hospital-based support, clinic-based support, and they'll show you what's in your area. You can also jump on your insurance provider's web portal. Most of the major insurance carriers have some sort of a search function like find a provider near me, and you can search by specialty, and palliative care is typically amongst the specialties that you can search for. And you can type in your zip code and see who's in your area and in your network too. I just had someone reach out to me last week with the same issue that they've been living with very severe pain from cancer. They had asked their oncologist for palliative care, and they referred them to an academic medical center like 6 hours away, they said. And they're like, that's not particularly helpful for me. It's 6 hours away.
Yeah.
And so I gave them that registry, and they wrote me back a couple days later to say they found someone 20 minutes away, and they were excited to meet
I
with
love
them.
it.
Yeah.
That's amazing. Well, so for my own information, are you able to offer palliative care like in virtual, like telehealth appointments, or is it only in person?
Yeah, so that's an active issue right now. So up through the end of the month, I believe, we've been able to offer telehealth. We've been trying to fight for an extension on telehealth visits, and so that may be sunsetting here shortly. At minimum, you need, if you're looking for someone to prescribe or manage medications, you need to be working with a team in your state who has a medical license.
Okay.
But how the telehealth is going to shake out is it's likely shifting towards in person for those initial visits by next month.
Oh, okay.
By
So
February
are people
26th.
going to
Yeah.
be grandfathered in if they get it now or no?
What I'm hearing is that's going to vary clinic to clinic. I think
Okay.
different clinics are kind of gambling on whether or not they're going to extend those or retroactively allow for reimbursement. You can still do it. The issue is it's kind of the reimbursement model's changing for that. And so there's going to be pressure to kind of get people back into the clinics. So now more than ever, it's important to know what's in your area. I will say, though, if you do have an illness that really makes it hard to get out of the house, palliative care, depending on where you live, they do have what are called community-based or home-based palliative care programs.
Oh, okay.
So even if telehealth's not an option or traveling to an academic center hours away is not an option, you can also search your area for community-based palliative care, which is typically a panel of docs, nurses, social workers, chaplains, and the like that will come directly to you, whether that's a home or a nursing facility or assisted living community. You can come and do in-person care without you needing to leave the house.
I love it. I'm so glad we went there then, and now we know about that. I love it.
Yeah,
Perfect. Well, I will be sure to include the links in the description for everyone. But yeah, any last words? You want to let people know where they can follow you and find you?
Sure. My website, howtotrainyourdoctor.com. It's got all my links and my contact info. Otherwise, you can find me at the same name, How to Train Your Doctor, at Instagram, Facebook, YouTube, TikTok.
Well,
And
perfect.
feel free to drop me a line.
If anybody needs a cheerleader, follow this man. Perfect. Well, thank you so much, Matt. This has been a pleasure.
Thank you for having me. It was great to be here.